before we get into talking about how the system actually works, we're going to go through a little bit the reasons for the case for change, I guess. So as you can see in this table, since 2012, overdose deaths due to prescription medicines has actually been higher than deaths due to illicit drugs and deaths due to the road toll. So this statistic's been really, really surprising to a lot of people. I think a lot of the general public kind of underestimate how risky prescription medicines can be. Most health professionals are probably very well aware, but I think we really need to get the message out there to the general public that these medications can be really harmful and dependency is a real issue. You can see also in this graph, supply of oxycodone since 2000 is the red line, and then corresponding deaths due to prescriptions is the blue line, and deaths due to overdose due to oxycodone is the red line. So there's definitely a parallel increase there. So there's been 34 recommendations since 2012 by coroners to have real-time prescription monitoring in Victoria. So it's something that's been on the policy agenda for a long time and is finally coming in the state in 2 weeks' time. And then, yeah, this graph just shows again pharmaceutical overdose deaths against illegal drugs and lives lost on the road. So blue line being lives lost due to road toll, red illegal drug overdoses, and green pharmaceutical drug overdoses there in Victoria.
Yes, there's been a fourfold increase in the quantity of prescription opioids provided in Australia and dispensed in Australia, and but these are the figures from the United States that show there's a correlation between supply and harm, the overdose deaths. And we saw that with the heroin shortage. As soon as, like, in 1999, I think there was one overdose death, heroin overdose death a day on average. When the heroin shortage happened, the number of deaths plunged. So with the increase in supply of prescription opioids in the United States, we've seen a very high correlation between that and overdose deaths as well. So, you know, since 1999, not only have we seen a quadrupling of the quantity of prescriptions, but also new entities like fentanyl and buprenorphine. So in the United States, this is, you know, when the United States, what happens in the United States happens, the rest of the world follows, as happened in the global financial crisis. So we're now seeing the stage where we're at the stage where there are more deaths from drug overdose now than there were at peak car crash deaths, peak HIV/AIDS deaths, or peak gun deaths. So we've now reached a situation in the United States where there is an opioid overdose crisis. And looking at the individual drugs, this is just the trends in supply of methadone. You see that peaked in about 2006 when methadone was being prescribed for analgesia, with prescribers not really being familiar with the complex pharmacology of methadone. In terms of overdose of morphine and other simple opiates and semi-synthetic opioids increasing. In 2010, we saw a huge increase in heroin-related deaths, and that was due not so much due to prescription monitoring programs, which were not really fully effective at that stage, but because of changes in marketing by transnational criminal organizations, Mexican and South American organisations. But the most disturbing thing has been the increase in synthetic opioids other than methadone, which is fentanyl, non-pharmaceutical fentanyl and fentanyl analogues, and novel synthetic opioids. It's the case now that a drug dealer in the United States can buy a kilogram of fentanyl, illicit fentanyl, for $2,000 to $3,000, mix it into heroin, mix it into cocaine, mix it into counterfeit OxyContin or Xanax or other medications, traffic it on the street to people who unwittingly die of a fentanyl overdose without even knowing that they've bought fentanyl. So in Australia, opioids use is pretty widespread. We had, in this period, we had 3 million people used, 13% of the population received a prescription for an opioid, and of those 5% got 61% of the opioids, probably people who are on long-term chronic treatment for non-cancer pain or taking very high doses. This is the base supply of pharmaceuticals in Australia, trends up to 2015. That's codeine, methadone, morphine increased earlier on and then plateaued, and the big increase has been in oxycodone, and also a big increase in fentanyl and buprenorphine. That's the trends in pethidine, which is not a very good drug anyway. So these are just to set in context the kinds of overdose deaths we're talking about. You can see that pharmaceutical drugs contributed to 414 overdose deaths in Victoria in 2017. And of those, the leading category of drugs was benzodiazepines, also involved, opioid analgesics, which compared with the number of heroin overdose deaths, pretty close to that. Also antidepressants, antipsychotics, and Z drugs. So this is where it fits together with the road toll and illicit drugs. So more deaths from prescription drugs, involving prescription drugs than involving illicit drugs. And of the drugs, this is over this period, 2019 to 16, the leading drug involved was diazepam. The drugs in green are drugs that will be monitored with SafeScript. And you can see there are a mix of benzodiazepines, opioids, and another benzodiazepine, and quetiapine, which is an atypical antipsychotic. Excuse me. So if you look at the top 30 drugs, the ones that aren't included in monitoring are in blue. The opioids, SafeScript opioids, are in green, and the other psychotherapeutic drugs are orange. So you can see that amongst the leading 30 drugs, there's a very big representation of the drugs that we will be monitoring. But this doesn't take into account the prescription volume.
Yep, so the medicines that we are monitoring, it's all Schedule 8 substances. It's including methadone and buprenorphine, and then selected Schedule 4. So there's been quite a lot of interest in why we've chosen the medicines we have. Austin Health conducted a literature review. They looked at emergency department data, Poisons Information Centre data, Coroner's Court data, and ambulance statistics as well, over about an 8-year period to decide or find out which drugs were contributing to the most harm in Victoria. And it was really clear that benzodiazepines needed to be included based on that. Also the Z drugs, so zopiclone and zolpidem, contribute to a lot of overdose deaths. Quetiapine, it was also very clear that that needed to be included and is very high risk. Codeine as well, so low dose codeine. So the codeine products that were kind of previously over the counter and now Schedule 4 will be monitored by the system too. So just to talk through how the actual system works. So the idea is that when a patient visits the doctor will be typing in to their computer to make a prescription. When they type the drug name into their prescribing software, they'll get a notification pop up on their desktop to let them know whether or not they need to check SafeScript. So the notifications are colour coded, either green, amber or red. So green meaning there's probably no risk, the patient doesn't have any history in SafeScript, probably no need to check the system. Amber means there could be something that's potentially high risk, so the system should be checked. Red is more like an alert for a very high risk situation. So for instance, the patient has seen more than 4 doctors in the past 90 days, 4 doctors at different clinics as well. And in that situation, the prescriber should definitely check the system. Then the doctor makes a decision about whether or not to prescribe. So that's something else really important to understand. SafeScript doesn't tell the prescriber what to do. It doesn't say you cannot prescribe, it just provides more information for them to make their decision. So if safe, the doctor will write the prescription out, give it to the patient, then the patient visits the pharmacy and the pharmacy takes the prescription in, and the same thing happens. So when the pharmacist types in the patient name and the medication, they'll get a SafeScript alert. So either green, amber or red, depending on whether or not there's anything high risk in the system. Then the pharmacist decides whether or not it's safe to dispense. If so, they'll dispense, and the record of that dispensing goes into SafeScript to compile the database. So as some of you may know, we're going live in the Western Victoria Primary Health Network region the start of October, so less than 2 weeks now. The rest of the state go live is going to be in April next year. There will still be access for clinicians in areas other than Western Victoria who do want access. That's okay. We're just doing a bit of a soft launch to make sure that the extra supports we have in place are adequate, and to make sure there's sort of no system glitches that need to be sorted out before wider rollout. And also it's important to know that use is not mandatory for the first 18 months. So up until April 2020, it's not going to be mandatory for clinicians to check SafeScript. After that, it will be. Yeah, so hopefully you could see from that video we've tried really hard in the design of the system to make sure that it's really integrated in your workflow. It doesn't require you to enter in extra data or search confusing databases or anything like that. It's integrated with clinical software, so with those notifications popping up, yeah, there's sort of nothing extra you need to do in order to interact with the system.
Well, with you can see that the prescriber, the pharmacist or the nurse practitioner would get a notification if they're connected to a prescription exchange service. The prescription exchange service is a system that enables the electronic transmission of prescription data, and that helps to overcome what's it called when you transcription errors. Sometimes the pharmacist will get a paper script, transcribe it into their own software, and then make a mistake in that transcribing, and that can cause harm. So many of the clinical software, prescribing software, has this kind of connection. It's called the prescription exchange service. That will immediately send that information about that prescription for that monitored medicine to our central repository, so the doctor in another practice or the pharmacist can look at that within a few minutes without having to do anything extra. So then there will be that notification, which will be green, amber or red. If it's red, it will mean there is an alert there, and there are 3 kinds of alerts. There's the opioid overdose threshold alert, there's the risky combinations alert, and there is the multiple provider episodes alert. So I'll go through each of those. The reason we have an opioid overdose threshold alert is that, in fact, there's now very good evidence from numerous studies that have looked at data from prescription monitoring programs and looked at coroner's data or medical examiner data in the United States, and found there's a very strong correlation between dose of opioids in terms of morphine equivalent dose, which is a way of converting all the different opioids into one morphine equivalent dose, and overdose death. The higher the dose, the more risk there is. So these are the 3 of those studies, where you can see that in blue that's a dose of 1 to 19 milligrams, and we've compared these other doses with that dose. And so people getting 20 to 49 milligrams, which is under 50 milligrams in this study, was 1.2 times more likely to overdose, 1.9 times more likely to overdose, 1.3 times to overdose. When the dose goes to 50 to 99 milligrams in purple, you can see there's quite a substantial increase in risk of overdose. But when it gets over 100, there's something like an 8 or 9-fold greater risk of overdose in this particular study, a 7-fold increase in this particular study. So even at what some people would regard as a relatively moderate dose, there's still an elevated risk of overdose. So and also, one of these studies in Canada looked at people who commenced opioid treatment with opioids, analgesics, and followed which ones transitioned to higher doses. And those people that transitioned to 200 milligrams morphine equivalent dose or more, 1 out of 32 of those died of a prescription opioid related overdose. So, I think we've come to a stage where we're realizing now that opioids, particularly that we use in treating pain, can be particularly hazardous, and we're trying to encourage doctors to take a risk-benefit assessment for every patient, consider their risks and follow them with their risks and look at their dose and bring them back to a safer dose. So they will get an alert, an amber alert when they get to a dose in this category, under 50 milligrams, more than 20 milligrams, and they'll get a red alert when they're exceeding when they're in 50 to 99, when they get a red alert when it's 100 milligrams or more in morphine equivalent dose, and be encouraged to bring them back to taper them to a safer dose, or consider deprescribing. So then there's the risky combinations. Particularly the problem is with benzodiazepines mixed with opioids, or one opioid mixed with another opioid as well. So they'll get a message about that as well. We know with benzodiazepines that the receptors that they act upon are co-located in the medulla in the brain near the respiratory centre. They sometimes share different enzymes that metabolize each of them. We know that benzodiazepine use is associated with harm amongst people who inject drugs in terms of needle sharing and other high-risk behaviours. They're commonly found in drug overdose deaths, like they were found in 58% of Victorian overdose deaths. And you saw diazepam was the leading drug that involved. Also, there's a study by Paul Dietz at the Burnett Centre that looked at, it was a case control crossover study where they asked people about their most recent overdose and considered a number of risk factors preceding that overdose compared to another period. They found that there was a 28-fold increase of overdose risk if they had been using a benzodiazepine before they injected. So we also know benzodiazepines relax the upper airway, so you get obstruction of the upper airway, and also they blunt the response to low oxygen or high carbon dioxide. So that's a particularly under-recognised problem with benzodiazepines. The third category is multiple provider episodes. People have seen more than 4 different doctors from different clinics, or received these monitored medicines from 4 or more different pharmacies. In a 90-day period, there will be an alert going back to the doctor to tell them, and that encouraged them to look at it and manage that. So just to give you a quick, brief description of some cases, you can have all the statistics in the world, but I think we talk about our fellow human beings. Mrs. A.B. was a 44-year-old woman with a history of schizophrenia and anxiety and depression. She had received medicines from 7 different doctors, the same medicines, and she died of a drug overdose involving the monitored drugs plus some other medicines as well. Mr. R.D. was a 37-year-old man. He had marked curvature of his spine, which is pathological and causing him increasing pain, so he was on high doses of opioids. And he'd had 11 admissions for inflammation of his pancreas because he had an alcohol problem as well. And in the 4 months before he died, he got medicines from 19 different doctors, each of whom was unaware of that medicines. And so he died of combined drug toxicity with a number of benzos and codeine and some other medicines as well. James was a 24-year-old man who was struggling with addiction to his medicines. He had depression, anxiety and insomnia. He became addicted to his medicines. He had multiple admissions to rehabilitation and, as often happens, relapsed into problematic use. Made multiple other attempts, got his friends to lock up his drugs in a cupboard, but his pattern of use was to wake up in the morning, go out and visit different doctors, get a stash of drugs, go to work, come back at night and take the drugs. he got into real trouble. He lost his job. He got into financial difficulties. He had arguments with his girlfriend. She left him. He lost hope and committed suicide. So in the 3 years before his death, he'd seen 19 different doctors, gone to 32 different pharmacies, each of them unaware of the supply by others. And many of those scripts were non-pharmaceutical benefit scripts, which meant that they weren't picked up by the PBS prescription shopping hotline. And he died of a combination of different drugs, many of which we will be monitoring. So you can see these kind of cases, what led coroners to recommend real-time prescription monitoring. And that's why we've got an alert to draw people's attention to that. So I've just tried to look at, one of the things we come up against is community prejudice, where, well, why should we be spending money on people who are addicted? All they've got to do is stop taking the drugs. And anyway, who cares about them? Well, every life is precious, and people have family and friends who will be a huge loss for them. So I've just tried to categorise them into different categories too. There's people who either become dependent intentionally and misusing drugs intentionally, or unintentionally drifted or escalated their dose and started seeking drugs from other doctors and mixing their drugs with no intention of just seeking to be intoxicated. Also, there's people who are pain, for instance, for opioids, pain patients or non-medical users. There are patients who start, opioids, for instance, or other psychoactive drugs, may catastrophize their problem. They may feel, well, I've injured my back is my living, how am I going to live? They interpret their pain as being catastrophic. Other people are chemical copers. They're described as chemical copers. They've got unpleasant feelings and emotions, and they feel better if they're taking these medicines. It's not just for analgesia or anxiety, it's for unpleasant thoughts and feelings that they have. And they often feel, well, I've got the pain, you're my doctor, you give me the drug. I need that drug you can solve my problem. So they've got an external locus of control. Rather than we're now encouraging people to be active and take control of their own pain. And then people also deny problems, they're uncomfortable about it. Denial's a well-recognised psychological mechanism for avoiding feeling uncomfortable, and they rationalise their drug use. I mean, they say things like, well, I didn't feel I was getting enough, so I went to another doctor. I still couldn't control my pain. Look, I thought I tried to characterise the spectrum of people in terms of, sorry, where are we? There are people who take these medicines and adherent, take them for the short term, which is where they're supposed to be most useful. They become chronic long-term users. They escalate their dose. They're proceeding along the spectrum. They take a very high dose. They're getting at increasing risk. And they start using multiple providers. They get very high opioid doses with concurrent depressants like benzodiazepines. And then there are people who may be using illicit drugs but not using them intravenously. And then there are people who are using them intravenously as well. So I think the common perception is, well, why should we be spending money on these people? Well, there are a range of people, and every life is precious anyway. So, do you want to talk about that?
Yeah, so I suppose something we've been worried about in the project is that doctors and pharmacists and nurse practitioners feel that they don't have the skills or support available to be able to sort of respond to patients who might be suffering really complex dependency issues. So the SafeScript project isn't just about the IT system, we're also putting in a range of other supporting measures so that clinicians can upskill and so that there's other supports available for patients. So this is just a bit of an overview of what we're doing as well as the IT system. So there's online training modules available for prescribers and pharmacists. So they've been developed by Western Victoria Primary Health Network and the PHN Alliance with the help of NPS Medicine Wise. There's 3 online modules, and there's also going to be face-to-face training, about 50 sessions across Victoria. So the online modules, and I'd encourage everyone to get online and do them. They're even open to, even if you're not a pharmacist or prescriber, you can actually access them through the NPS website. So the first is how to use the system, so more like the IT side of things. The second module is best practice prescribing of high-risk medicines and current evidence as well. And then the third module is about how to have difficult conversations with patients who might have dependency issues or have very complex pain problems and that sort of thing. Good. And then we're, with the help of Turning Point, we've got a few initiatives up and running. So the pharmaceutical helpline went live on the 2nd of September. So this is a helpline similar to Direct Line, which some of you might be familiar with. So it's the main difference between the pharmaceutical helpline and Direct Line is the SafeScript helpline is staffed by nurses. So they've been trained to have a little bit more, I guess, clinical knowledge about these medicines, and they're probably better able to help patients. We were sort of quite conscious that a lot of people who have prescription medicine dependency issues might be unwilling to call Direct Line because they sort of see it as more like an illicit drug helpline. So we've put in place a SafeScript helpline. It's open 9 to 5. After hours, it redirects to Direct Line, so it is actually available 24 hours. And we, the nurses have the ability to also register if patients need any help further on down the track. They can follow up and that sort of thing. Turning Point are also helping us set up another initiative called GP Clinical Advisors. So the idea is that there's going to be about 12 GPs throughout the state who are going to be upskilled in how to manage complex patients who might need pharmacotherapy or just better pain management or anything where if a GP feels like they don't have the skills to be able to help that patient directly, they can refer on to the GP Clinical Advisor or call the GP Clinical Advisor and get some extra assistance from them. And they're currently recruiting as well. So I think if you go to the DACUS website, if you're interested or you know someone who might be interested, recommend going to the DACUS website and you can express interest in that. We've got a public awareness campaign also that started at the moment just in the Western Victoria Primary Health Network, but the ads will be coming online in metro areas in March, and I've got the ad after this slide to show you, which we've been producing over the last few months. And then also finally, we're working with Reconnection to make sure that there's enough support out there for patients who are suffering dependency issues with benzodiazepines. So Reconnection, we've provided extra funding so they can make their benzodiazepine toolkit available. Previously this was, you had to pay to access it and they would send you a hard copy. So now it's available for free on their website. It's a really good resource for anyone who sort of needs assistance with knowing how to taper down benzodiazepines. And they also provide secondary consultations for patients as well who need extra support coming off benzodiazepines. I think, yep, so this is the ad.
Prescription medicines can provide essential relief after surgery. They can treat back pain, anxiety, and sleep disorders. But some are addictive. Prescription medicines kill more Victorians than the road toll. That's why the Victorian Government is introducing a new system to help you stay on the safe side. Speak to your doctor or pharmacist or search SafeScript. Authorised by the Victorian Government, Melbourne.
Okay, and patient privacy finally. So we're really conscious of the fact that patient privacy is such an issue at the moment with anything to do with health, as we've seen with the My Health Record situation. So it's important to know that SafeScript isn't connected to My Health Record. If any patients ask, and we get that question a lot, the data doesn't come from there or go to My Health Record. Only doctors, pharmacists and nurse practitioners who are actually treating a patient have access to a patient's record on SafeScript. So it's not just any doctor, pharmacist or nurse practitioner, and no other allied health professionals at this stage have access. The information is encrypted when it's sent to the database, so we'll make sure there's no interception happening. Also multi-factor authentication is required to make sure that you don't just get access to someone else's password and log in as them. You actually need to verify your identity using a telephone each day. And also it's patient privacy, and the information is protected under law. It's an offence to access someone's record if you're not actually treating them, and pretty serious penalties can be imposed under the Drugs, Poisons and Controlled Substances Act.
Yeah. Plus, we're auditing people accessing patient files as well. So there's a record to track who accesses each patient's file. Yeah. So, yes, if you want to know more, go to our website. We've got our literature review, the Austin Health Literature Review. That's online as well, on that site there. And here are the resources for the training resources as well. So that's all we need to say. We're really very interested in what you've got to say, and any questions or any suggestions, we're very happy to hear.